So I think these are just wonderful discussion points. And again, I think this is what is facing all of us clinicians and payers, especially in prostate cancer, because lots of new drugs, lots of therapies, lots of unknown questions, lots of issues about sequencing. We're sort of stuck with our clinical trial design right now because pretty much every study that's been designed in order to get by the FDA, it's been about overall survival. Fortunately, we've had a little bit of break with 302, with radiographic progression-free survival. So let's circle back to these key topics of discussion that we had alluded to in the introduction in terms of what we need to do moving forward. Jeff, I'm going to let you take this.
Yeah, I'll throw this out there, and you guys can jump in and add your comments. But I think we've talked quite a bit about the first one, the pathway, the formula development and sequencing. So I'd like to address the second one first, or next, and that's payment reform. So I think a lot of us have seen where we've come from over the last 5 years. It's interesting that just 5 or 6 years ago, we were paying percent of billed charges. So we've actually gone through 2 or 3 iterations to that, to a WAC pricing model, to some kind of fee schedules, and now most people are using ASPs. But really what I think we need to do is we need to do a better job of aligning the incentives, because there still is, the incentives between the payer and the provider are not the same right now, in that there is still an opportunity to make money by using drugs. So what I think we need to do is we need to change the payment model to lower the reimbursement for medications, but increase the reimbursement for cognitive services and the other things that our providers do for our members. So again, kind of aligning the incentives and then sharing the risk, because no offense, but I think right now the two parties that bear the brunt of the risk for costs are the payer and the patient. So at some point, I think the provider has some kind of responsibility to make cost-effective decisions and have some kind of financial responsibility to that, along with the pharmaceutical company. So really how we figure that, I don't have the answer to that, but I think one of the key things around payment reform will be figuring out how we share risk among all of the different stakeholders.
But I think the Affordable Care Act has at least charted a course.
That's the objective.
And again, I'm going to say that I'm not sure most providers are going to be particularly happy with the course, and that course is this. You ain't going to have to convince me. You're going to have to convince the people who run your integrated delivery system. In other words, you're going to be accountable for both the cost and quality of care that you deliver to your prostate cancer patients. And that goes from the moment that you screen them to what you decide is the treatment modality to how you treat their advanced disease. Every single step. What you're going to do is going to be under the microscope of your risk-bearing entity, and that's going to be your ACO, or integrated delivery system, and talk about a dramatic change in dynamics. We won't be having this talk. You'll be having it with them.